shows you the cases, malaria cases, incidents in terms of cases. And the one on the right shows you deaths, okay? And you can see that there is a huge gap between where we want to be and where we are currently. The blue line is where we are currently, and the dotted line, so as at 2024, this is where we are, close to, we are at about almost 230 million cases. However, in terms of the targets, the target is that by 2024, we should be around 55 million cases. But you can see that there's a huge gap, both for the cases and for the deaths. So we do not seem to be on course when it comes to the global technical strategy target. So what are some of the threats that are making us to, go off the trajectory that we really want to be in terms of malaria control? And I'll be sharing some of them with you. I mean, if you look at it globally, this chart is a summary of everything, but I won't have time to go into all the details about of this summary. But the factors, when you talk about the threat and the challenges to malaria control globally, these are the factors. So you have the interventions or the tools. How effective are they? You have the population, the people. People move. People are the host for the parasite. And then you have the health system. How strong is the health system in terms of responding to malaria, case management, preventing malaria, and all that? And then you have community involvement, which is very, very important as well in the malaria control efforts. And then you have environmental factors. I will talk a little bit about the environmental factors. And then you have finance. Finance is critical. And as we all know, in the global arena recently, there's been a lot of shifts in the fiscal space and a shrinking of the fiscal space when it comes to malaria control financing. So these are the factors that are responsible for the challenges that we face. And so I will speak a little bit specifically because in the latest the World Malaria Report that has just been released, one of the things that they emphasized is this resistance, the biological threats to malaria control efforts. And there is a lot of resistance that is developing, not only to the parasites, but even to the insecticides that we are using in the bed nets. And the bed net is one of the mainstay of malaria control efforts globally. Sleeping under bed nets is the mainstay of prevention. But then there are threats to that intervention because the insecticides that are used to impregnate the bed nets are now developing resistance. I mean, the vectors are now developing resistance to those insecticides. And so it's a big threat. And beyond that, there is also development of resistance to the drug that is used. We all know that artemisinin-based combination therapy is the drug that is used in the management of malaria. However, in Asia, there's the development of artemisinin resistance, and over the years they've been trying to contain it, but unfortunately that has now slipped into Africa, and there is a lot of concern that if we lose this particular drug, it will be a huge challenge to winning the war against malaria. But as we speak, there are 8 African countries where artemisinin resistance has now been confirmed. And there is also the invasion of Anopheles stevensii, which is a very peculiar vector to malaria that is found in urban settings and is very difficult to control. So that's also a big threat that has been found. And then another threat is diagnostic evasion, which, you know, what happens in this case is that you have some parasites that do not have the gene that is required, that can be picked up when you do a rapid diagnostic test. So those parasites, they are HRP2 deficient. They do not have that gene. And it is that gene that the active ingredient that you have in the RDTs binds to, for you to be able to pick the presence of a parasite in a blood sample. Now, when those genes are not present, what it means is that you will do an RDT test, and the test will be negative because that gene is not present in the parasite. But that doesn't mean that that person really does not have malaria. So they are evading the diagnostic tools that are available. So these are all the threats that are biological, that are compounding, you know, the threats, you know, the malaria control efforts globally. And beyond that, we also see a very massive drop in funding for malaria control. We were only able to reach 42% of the estimated amount that is required to fund malaria in 2024. And nobody knows whether this is going to increase. As at the last time, the Global Fund just did a replenishment of the Global Fund, and they were not able to achieve, they were only able to achieve about 52% or thereabout of the amount that they set out to achieve. So these are all the threats that are compounding the malaria control fight. And then beyond that is climate change that is also, you know, a factor to consider, and which is an environmental factor. We all know that this global warming is causing, you know, a lot of changes in the environment, and malaria is one of the infectious diseases that is very sensitive to climate change. It's very sensitive to climate change because of the life cycle, of course, of the malaria vector. You know that it is dependent on water. They need water to breed. They need water to, you know, to replicate, to lay their eggs and to grow and all that. And so as temperatures rises as a result of the climate change, there's also a shift in, you know, rainfall patterns. There is more rainfall and flooding and all that. And because of that, you have the malaria vector cycle is now becoming faster than what it used to be. So there's an acceleration in the cycle. The malaria eggs, the parasites, the eggs are becoming adults faster than they used to be. So that cycle is being affected by climate change. And then there's also an expanding range of the types of vectors that are available. Those vectors that usually were limited to, you know, highlands or lowlands are now being found in highlands because the temperature is rising. And those areas that used to be very cold, where you do not find vectors, where they cannot survive and everything, because of climate change, because of global warming, those areas are also now, you know, becoming conducive for certain types of vectors. And again, we can't predict, you know, rainfall patterns anymore because of the, you know, dwindling. And we hear that in 2026, for instance, meteorological surveillance has revealed that there's going to be a lot of rainfall this year, and there will be a lot of flooding. And you know what happens when there is flooding? There's water everywhere, stagnant water. Mosquitoes are now able to breed, unlike when there is no water everywhere. So these are all the factors that contribute to, the challenges that we face in malaria control efforts. And I think I've talked about this, but then again, so now what are some of the efforts or the breakthroughs or the recent developments in malaria control efforts? I talked about the main intervention being vector control, which is the use of bed nets, insecticide-treated bed nets, actually. And we also have indoor residual spraying, although that is not really rolled out because it's quite expensive to roll out and to scale up. And then there are other supportive, interventions like environmental management, which includes integrated vector control or vector management that also incorporates larviciding, controlling the environment and things like that. And then on the case management side, I talked about artemisinin-based combination treatment, which should be instituted as soon as anybody comes down with the symptoms of malaria. But then in addition to that, just about 2 years ago, WHO approved malaria vaccine, and about a year ago, another one was added to it. So we have 2 WHO-approved malaria vaccines that are being integrated into childhood immunization programs across Africa. So as at 2025, 24 countries have introduced malaria vaccine into their malaria control programs, and more than 10 million children have been more than 40 million doses have been delivered, and every year 10 million children are targeted across these countries. And of course, in Nigeria, the vaccine, the one that is rolled out in Nigeria is the R21, which is being implemented in just 2 states. And even in those 2 states, we are having issues with, the uptake of the vaccine, the coverage of the vaccine and everything. But I mean, the good news is that Nigeria has also introduced the vaccine. It's currently being implemented in Bayelsa and Kebbi states. And a 25% price reduction on R21 vaccine is also accelerating access, because I mean, what that means is that the R21 vaccine is much, much cheaper than the other one. So what is the role of data analytics in malaria control efforts? Of course, we know that WHO has now designated malaria surveillance as a main intervention. Before now, they used to call it a supportive intervention across all the main interventions that were used for malaria control in the past. But now, given the fact that once a country begins to move from control to elimination, surveillance becomes very key, in ensuring that you are tracking every case, you are following up on every case, and you are monitoring every case. And so malaria surveillance is very important when in the malaria control efforts. And I think it is in this space that malaria data analytics is very critical. So in terms of the policy environment within NMEP, or that's the National Malaria Elimination Program, the National Strategy for Malaria Control has, provided something like a blueprint for a data-driven malaria control in the future and even now. So Nigeria is embedding this new paradigm into its national policy. They are creating the governance and infrastructure needed to support, a data-centric approach. So in the malaria control program, there is what we call the Malaria Data Repository. That's the National Malaria Data Repository. I'm sure that some of you are familiar with that. This is like a national warehouse where all data that is related to malaria control in Nigeria is warehoused, and that system sits within the National Malaria Elimination Program. So it not only warehouses routine malaria surveillance data, it also warehouses routine entomological data. It also warehouses non-routine intervention data like SMC, all the campaign, ITN campaign, SMC campaign, all those campaign-like data are also warehoused in that database. So there's a huge database of data that, can be leveraged for malaria data analytics that will be, informative in supporting decision-making, policy decision-making, and even programmatic decision-making. So when we talk about the role of data analytics, so where does data analytics, modeling, and all these other types of data management come into play? So alongside biomedical advances, there needs to be a paradigm shift in data analytics, and artificial intelligence and machine learning are, now enabling public health officials. While Prof was talking earlier, he was talking about artificial intelligence, and that if you're not careful, if you give yourself solely to it, you will not be able to think, because, it is amazing what artificial intelligence can do. And I think this is the point where in the malaria control efforts, we need to begin to explore the benefits of artificial intelligence and machine learning in enabling, public health implementers to use data to inform decision-making, programmatic decision-making, policy decision-making, and just to move beyond, historical reporting, to real-time monitoring and even forecasting of data, which, I talked about earlier in relation to climate change. So what is the path forward when we talk about data analytics for malaria control? So it is going beyond, broad strokes, I will call it, to being precise, precision targeting, navigating, that complex interplay of, we have funding constraints, we have all sorts of threats. There are also climatic changes that are going on that we really need to be on top of, especially when it comes to, meteorological surveillance. Meteorological surveillance is very critical now in the malaria control effort. Why? Because of climate change. We need to begin to forecast, seasonal and epidemic surges that could happen as a result of climate change. And at the moment, even though there is a meteorological component of the data repository, the National Malaria Data Repository, that part is yet to be, further elaborated, is yet to become really functional, such that we can now integrate, malaria surveillance, health facility data reporting with, real-time meteorological surveillance and forecasting of, epidemic surges and things like that. So tracking the evolution of threats, also like drug resistance, near real time, is also going to be very critical. So the approach is not just going to be reactive. We need to move away from reactive approach, to something proactive, so that we are able to even predict when those things can happen, to say, okay, in the next 12 to 18 months, there's likely to be an upsurge in malaria cases in this particular area. So we are very precise. So those areas can now go and say, okay, if there's going to be a surge, how prepared are we? So then we can talk about preparedness, for tackling, these surges and for dealing with them. And then we also need to optimize. That helps us to optimize, the impact of every dollar that we spend, okay, on the malaria control effort, especially in this season where there is a lot of, shrinking of malaria resources. So I wanted to share some examples of what some people have been doing in terms of data analytics in the malaria space. Some of these examples, these are published data, and I can provide the references for you to look them up at your spare time. But they are just examples of how people are using, specialized data analytics, in malaria control efforts. So this is an example where they're doing some more granular surveillance, doing hotspots, uncovering hotspots using spatiotemporal models to look at where malaria hotspots are. This is an example in Kano State. So hotspots, areas where you have malaria surge, so that you can target your intervention at that area. We're talking about intervention targeting nowadays because, the epidemiology of malaria is so varied across the country that you can't use one intervention to do everything. So you really need to know what is happening where, and it is only data that can show you. And we have data, but we now need to begin to analyze that data in such a way that it becomes useful for intervention targeting. Okay, so this project is an example, or this paper is an example of using spatial temporal models to look at hotspots for malaria. Another example is, how genomic and molecular surveillance is being deployed. So when we talk about the genomic surveillance is, going beyond just looking at, test positivity and test negativity and all that, but looking at, genomic data to look at the epidemiological trends and tracking, the emergence and spread of drug-resistant parasites, in near real time. And this is being done, and dashboards are, now used to provide decision making. What happens is that the data is collected, from the lab, and then they feed the data into a system, and that system produces, like a dashboard that is able to then show you as a decision maker, as a policy decision maker, that in the next, this parasite resistance is happening in this area because you now have data to show you, and you are, doing some genomic, monitoring of the data and molecular surveillance. The other one on the right is data-informed vaccine introduction. So when the vaccines were introduced, there was a lot of shortage of the vaccine. It couldn't go round. And so WHO had to develop, a strategy to rationalize or to ration the vaccine. And they now had to use data to determine which country would get the vaccines first. And they were only able to do that because they used data analytics. And so they were able to determine the areas where the malaria burden was high. They looked at high malaria burden, they looked at the population, they looked at, many other parameters to come up with, okay, which are the countries that we are going to prioritize to deploy this malaria vaccine. And that went a long way in helping to introduce the malaria vaccine. So generally now, what we are looking at is that in the future, which I don't think is really far, the future of effective malaria control would be now integrating all these our data ecosystem, where we have multiple streams of information that can now be synthesized, to provide a comprehensive and actionable intelligent picture, like an architecture that goes beyond individual or single, programs. We need to now begin to think about how we consolidate and integrate data. We are putting in spatial intelligence. We are putting in genomic surveillance. We are putting in climate and, meteorological data. We're also putting in early warning systems into that so that, from all these multiple sources of data, you are now able to, generate an intelligent picture of what needs to be done and where and when, in a way that it becomes easy for malaria policy decision makers to take decisions about what intervention do we deploy, where do we deploy them, when do we need to implement those interventions, and if we deploy those interventions, what is the likely impact that we are going to have? How much is it going to cost us? You understand? So all those multiple kinds of decisions, which are complex decision making, if I may say, would be guided, would need to be guided by data. So we need to reclaim the momentum in the fight against malaria. As I showed earlier, that we are losing the momentum and there's a huge gap between where we want to be and where we are currently. However, we see that there's a clear path forward. The tools are available, but we need to build more intelligent, more precise, and predictive malaria control programs so that we are not just reactive. We are not just, reactive to issues. We are proactive. We are looking at the future, and we are, already preparing our systems, our structures to be able to respond when those threats come and when those epidemics break out in anywhere across the country and even across the globe. So this is where I rest my case. Thank you very much for your time.
Yeah, thank you so much, Dr. Oresanya, for that very beautiful presentation, man. It's been very, very enlightening, and I believe that people have gained one of the things. People have been busy writing, jotting, and listening to you. Let me just entertain a few questions, man, before we release you. Okay, so questions. Let's signify if you have questions. I think I have some too, so let's signify. All right, great. I'm sure that some of our scholars here will have questions, so I think I'm not disappointed.
Thank you very much, Dr. Oresanya, for that wonderful presentation. So, I have a question, and particularly on the area just where we stop on being proactive. So I would want to ask, particularly there was a review I did within last year that talked about that we are now having the SMPs that are very responsible for ECT treatment in the country. The thought they are despite the C580Y mutation in the country. So I really want to ask, what is the state of the population and how prepared are we in terms of mitigating this ACT treatment of resistance in the country? Okay, I want to believe. Did you get that, man?
Yes, I did.
Would you like
Do
to
you
take all the
want me
questions?
to respond to that, or you want us to take all the questions
Okay.
and then I can respond?
Okay.
Do you want me to respond to each question?
Maybe we'll take all the questions and then
Yes.
we'll,
Okay.
whichever one you prefer, ma'am.
It's fine. Let's take the questions.
Okay, thank you so much. All right, thank you very much, ma'am, for the beautiful presentation. Now, my question is also along the grants line. So, I understand that so many countries, especially in Southeast Asia, just like you also mentioned, are recording the emergence of ACT resistance. And then I also read somewhere that some countries in sub-Saharan Africa, there are studies that are showing disappearance of polio resistance, and then there's this return of chloroquine susceptible PF malaria in countries like Malawi and then I think Zambia also. So my question is also related to the first question. Are there studies in Nigeria currently that is geared towards tracking the emergence of ECT resistance currently? Thank you. Thank you so much, man. That's all. Okay, thank you so much for your insightful presentation, man. So, just like you said, I'm very much aware that malaria vaccine has been deployed in 2 states in Nigeria, Bayelsa and Kebbi. However, I will be interested in knowing the progress that has been made so far in terms of the coverage, just like you said. Then, if I may also want to know the specific time they commence the deployment of the vaccine, and if they actually follow the strategic plan that we know, or the vaccine rollout set that was previously published. Thank you. Right, thank you, sir. All right, thank you so much, Mark. So my question is on the one that borders on climate and entomology. Right, so currently I'm working on malaria dynamics in low and high burden, looking at the climatic factors. And in coming up with the model, one of the things that is required has to do with entomological data, looking at some of the parameters to explain the dynamics of the mosquito parts. So what currently, let me say that I don't have access to that as far as Nigeria is concerned. So the only thing now is just to look at other studies that have been done, look at some of the observations from the field that they had, and use that as a proxy to explain how climatic factors have affected further dynamics in these different regions. But listening to the talk you gave now we are talking about not being reactive, where we come to the state of maybe even having predictive models that is able to inform us there's going to be a kind of outbreak, especially when we have unusual situations. So now seeing that we need local data to actually inform that, and I'm not so sure about the availability of meteorological data to address. So what do we do in this kind of situation such that at the end of the day, I see able to come up with a predictive model that can inform decision that has to do with climate change and malaria control dynamics in different regions. Thank you. Right, thank you. Before
Sorry, just to clarify the last question. So are you asking about meteorological data that is entomological data? Oh, okay. Okay.
Okay, so Prof.
For your beautiful presentation. My concern is about the particular vaccine that is effective, but some people are reacting to it negatively. I want to find out whether there was an effort to check what aspects of the vaccine would be responsible for that negative reaction, And if there could be a substitute so that the vaccine can still be maintained and it could be used. I'm just thinking that since it is effective, it's just that some people are reacting to it negatively. Maybe there could be a particular parameter or content of the vaccine that could be moderated such that we can still take the vaccine.
Okay, thank you so much. And then my third question. Thank you so much for your presentation, Ma. Two questions. Number one has to do with the issue of resistance. You talked about, Ma. I remember the last time we had engagement, you told us, oh, resistance are forming confirmed in Nigeria, so it will not be nice, talking about that. But I saw now that you presented a map that shows 8 countries in Africa are now confirmed to have resistance, and Nigeria seems to be one of it. Okay, I want to confirm if I saw correctly, and then maybe they need to now start a serious work on that. Like you said, we shouldn't be reactive, we should be proactive. So because of the resistance now, I imagine if we have widespread resistance in Nigeria for ACT, how we are going to be able to cope with that. So just want to confirm if I saw correctly in that presentation that Nigeria is already now part of those with resistance. That's number one question. Then the second one has to do with the issue of vector control interventions. Now, I know that we predominantly use LLIN in the country, and most of the time, even though we talk about IBM, but it's really in the talk. It's not really being done. Now, my work has been around vector control. I've been looking at now with the intention of seeing the potential effects of IBM in the time to come. Now, yes, even though we don't have data around, for instance, environmental management, issue of breeding sites in the country, which could have one could have helped to like overlay that with malaria cases data in order to do a good work in that. Then we just have to, one now has to rely on, like my brother said the other time, trying to find proxy, to going around that concept. So I don't know if there are other data sources that we can bring in order for us to effectively assess some of this, maybe the potential impacts of IBM in the country, because we have been using LLI, permanently. So there are some kind of other data that we can bring in, and then that can help us to assess these effects much more in a more robust way. Right, thank you. So that's my question. I don't think we have exhausted the hands as were raised. So I will now hand over to Dr. Oresanya. You have the floor, ma'am.
All right, thank you very much for your questions. So I'll start with the first one. So the first one was on how prepared Nigeria is in responding to artemisinin resistance. And maybe let me just to clarify that when we talk about artemisinin resistance, it's a spectrum, and in some places, the resistance is not to artemisinin, but to the partner drug in the combination treatment. Okay, so in Nigeria, and this one will answer the next question about whether there are studies that are tracking resistance in Nigeria. So in Nigeria, every 2 years, Nigeria conducts what we call drug therapeutic efficacy studies. They carry out drug therapeutic efficacy studies to monitor the efficacy of the active ingredients in the drugs that we are using in the country. So what that data, so looking at the data that have been recently collected, although we do not yet have artemisinin failure in Nigeria, I need to emphasize that there is no artemisinin failure in Nigeria. But what the data has shown is that at the moment, all the artemisinin, the recommended treatment that we use for case management in Nigeria are still more than 90%, some of them even 97% effective. But when you disaggregate that data by the different geopolitical zones, in the southeastern part of the country, we've seen that there is a slight decline in that proportion, although it is still more than 90%. Do you understand what I'm trying to say? So, and that is not to say that there is a failure. However, Nigeria is being proactive because what WHO recommends in terms of dealing with artemisinin resistance is that you do not wait for it to happen before you begin to intervene. Okay, so, and there are several interventions that have been recommended by WHO to deal with artemisinin resistance. One of those interventions is to have multiple first-line treatments so that you take the pressure from just a single treatment and spread that pressure so that you can have multiple. Then another strategy is to rotate, your treatment. You rotate it such that you say over the next 6 months, we will use this in this area, and in another area, we will use a different combination therapy. So such that not everybody is using the same drug at the same time, which can lead to some pressure. And then also a lot of SBCC communication about people completing their doses, ensuring that they only give the drugs to those who are malaria positive, because that is very important. One of the things that drove ACT resistance was the fact that the drug was being given when it was not needed. Okay, and people don't complete doses, don't adhere to doses and things like that. So those are the things that cause resistance to the drug. And yes, Nigeria at the moment is already implementing the multiple first-line therapy, which is being proactive to preventing the development of artemisinin resistance. And then the third question is about the coverage of malaria vaccine and whether the vaccine was deployed as it was planned. Yes, so Nigeria's strategy for introducing the vaccine was a phased strategy. So the plan was to introduce it in phases. So the first phase was for it to be introduced in 2 states. And that is what happened. They introduced in Bayelsa and Kebbi. And if you notice, Bayelsa is in the south, Kebbi is in the north. And those are 2 different malaria transmission settings. So the plan was to learn lessons from the deployment in a state in the south and a state in the north, and the lessons that are gathered in terms of uptake, acceptance, and all those other things will then be used when they plan to scale up. So the second phase is the scale-up phase, which is supposed to actually happen in 2026, because the phase 1 was supposed to last for about a year or 2, and then they will go into the second phase. But I hear that there are some, there were some challenges with procurement of the vaccines, but I think they now have resources to procure the vaccine. So we expect that will go on as planned. And so the specific question again was about when it was deployed. So it was deployed in December 2024. That was when malaria vaccine was launched in Nigeria. It was in December 2024. And then the other questions were, all right, so there was another comment about negative reaction to the vaccine. I wasn't too sure whether she heard that from somewhere, or whether she thought that I said that, because I don't recall talking about people having negative reaction to the vaccine. However, just to mention that there is a very robust pharmacovigilance that is put in place for the malaria vaccine. I mean, and of course, like every other vaccine that is deployed in the country, there would always be, that system of reporting reaction and documenting them, investigating them, and finding out whether it is really due to the vaccine or due to something else. So I didn't say that there were reactions or that people are reacting negatively. What I mentioned was that there were some challenges with uptake, and not because people were reacting to it. The challenge with uptake was primarily because people were not aware that the vaccine was now available, and so they were not presenting their children to receive it. But in Kebbi State, one of the things that was done to deal with that was to use the SMC platform to give messages to the caregivers in their houses. So when CDDs went to the house to give SMC, they also tell the caregivers or identify whether children who are living in those households have been missed for malaria vaccine, and then they refer them to go and receive the malaria vaccine. The last question is around, the two of them are around data availability. Are there other data sources that can be accessed to look at the impact of malaria on IVM beyond using ITM data? Yes, there are other data that can be explored. I talked about entomological surveillance data, which before now was being warehoused in NIMA. But now, the NMEP's National Data Repository now has the entomological data inside it. So that data that was warehoused with NIMA before has now been migrated into NMEP's National Data Repository. So that data is available there and it can be accessed. All you need to do is to get in touch with NMEP. And also, if you want access to it, you can also speak with the head of IVM in NMEP, and that data can be made available for you to use. So I think I've been able to answer all the questions. I don't know whether I left anyone out. Am I okay? Did I answer all the questions?
Okay, I think you have been able to answer all the questions, except that we have one person here who is still, yes, I'll finally hand over to Prof, but I just want this person to say.
Okay, thank you very much, man. My own question about the drug resistance we talked about earlier. Like I heard one professor talk about it before that. It is now wrong to diagnose malaria clinically. But even in some private health facilities and some doctors, they still diagnose malaria clinically at this stage without using RDT or the lab microscopy. So what efforts are Please, so I aware, today people are aware about things like that. So that's my own question.
Okay, I think that should be the last question because of
Okay.
our time.
All right, so there's a lot of, the National Malaria Elimination Program is doing a lot about interpersonal communication, especially amongst health workers. And health workers are being trained. They are also being mobilized to understand that they need to test before treating. Okay, that every malaria, every fever case must be tested before it is treated as malaria. Because the reason is that the prevalence of malaria in Nigeria is dropping. It's not as common as it used to be in those days, that anytime you see fever, you just say, this is malaria. There are many fever or febrile illnesses now that are not malaria. So you need to test it and be sure it is malaria, because if it is not malaria and you are treating it for malaria, it will have a negative effect on the drug, and the patient will not get better. In fact, if it is a child, you can lose that child because that child could need an antibiotic. Meanwhile, you are giving the child ACT. Okay, and children do not have that kind of tolerance. They don't give you so much time to intervene when they are sick. And so that's why within 24 hours, if a child comes down with malaria, with fever, you have to be sure what you are treating. So there's a lot of awareness that is being created. Health workers are being trained. There's a lot of advocacy, communication, and social mobilization also that is going on at the community level to let even caregivers know that when their children are sick, they have fever, they should test before they treat. I hope that answers the question.
Thank you very much. Very grateful. So if it is not malaria, it is not malaria.
Yeah.
So you may check for something else. Now, I've had this body in my heart as regards the issue of funding, especially from NNEP going forward. Like looking at the case of analytics, data analytics and modeling. So what is the role of Malaria Consortium, NNEP, in terms of funding, maybe while preparing for global fund, building in funding for modeling and analytics going forward? I don't know whether you have anything to say about that.
Okay, thanks, Prof. So the way Malaria Consortium works, we support the National Malaria Program. And the way we do that is that if we have resources, funding for a stream of work that is related to what NMAP does and that aligns with the National Malaria Strategy, we bring that stream of fund, that the funding to NMAP to support whatever NMAP is doing. So for instance, if NMAP identifies a gap in malaria modeling, and we are able to take that gap and present it to some of our donors, and we get resources to meet or to fill the gap, then those resources are made available to NMAP. As Malaria Consortium, we do not, how do I put it? We are not funders per se. We are an NGO, although we have an arm, a US arm, that operates like a funder. Okay, so that US arm, again, we can present proposals to them if you have an innovative idea, catalytic, something that hasn't been done before, and that you feel if you do it, it can align with, you know, helping NMEP to achieve its NMSP objective or goal, then we can put that proposal together, present it to our MCUS body, which also functions like, you know, a funding agency. And if they approve, that resource can be made available. But generally, if we look at the malaria analytics and modeling space, one big funder of that space is the Gates Foundation. And they're still putting in a lot of resources into that. And there are many opportunities that come out. And I think one of the things that we also need to look at, Professor Bakare, is that sometimes when some bids are put out there, call for proposals, because there are some calls for proposals that are out right now. They may not specifically talk about modeling, but you can incorporate modeling into it, and that will automatically make resources available for modeling. For instance, there are bids that are out there now on climate change. A lot of money on climate change issues. Of course, modeling is critical for climate change. Data analytics is critical for climate change. So you don't necessarily have to say this is climate change, but what within that climate change call for proposal can you tie modeling to that will now make resources available for modeling?
Thank you for that. Yeah. All right. So, in the absence of no other question, we would like to release you and also appreciate your time. And especially the first week of the year, we really appreciate you. And then hopefully we believe that we'll be able to work more together this year going forward. Thank you very much.
Thank you very much for having me. God bless.
Have a wonderful time. God bless you.
Amen.